It is my pleasure to present today this talk on abdominal pain in acute and emergency paediatrics. I am Dr. Eleanor Glenday, consultant paediatrician at Worthing Hospital within Western Sussex NHS Trust. I'm going to look at the evidence behind the clinical practice for children and infants presenting with abdominal pain. In particular, I'm going to start by looking at the background and the epidemiology of abdominal pain in emergency department settings. I'm going to look at signs and symptoms, and in particular focusing on the red flag signs of abdominal pain. For the diagnosis, I'm going to talk about the evidence behind the use of pain scores in both nursing and medical practice. For the management, I'm going to look at the evidence behind the investigations that we use for abdominal pain and how these can help our practice. And then I'm looking specifically at the management of appendicitis, since this is a very common emergency department presentation. So what do we need to know about abdominal pain and why? Well, it is one of the big six in paediatrics. It's one of the most common clinical conditions and scenarios. The number one presentation, as you well know, is fever. Bronchiolitis and croup is very high up in the presentations. Diarrhea and vomiting, head injury, and then asthma and abdominal pain are equal fifth. So it actually represents 5% of all presentations to emergency department. Surgery is actually only needed in 1 to 7% of cases, and in up to 15% of cases there's no definitive diagnosis, and a vast number of these are medically unexplained causes of abdominal pain, for which there's no physical cause as such. The diagnoses are 65% medical, approximately 5% surgical, and in 30% non-specific or no diagnosis found. Other studies have differing proportions. Some studies suggest that approximately 65% are acute gastroenteritis, 15% is very non-specific abdominal pain, of which a diagnosis is not found, 15% approximately is urinary tract infections, 5% is referred pain from respiratory tract infections or post-surgery pain. So the key information that we need in taking a history during a patient with abdominal pain is the duration and progression of the symptoms. Is there any blood or bile in the vomit? Is there vomit? Is there loose stools? And if so, is there blood and mucus with this? We need to do an AVPU, take the heart rate, the respiratory rate, the saturations, and the cap refill time. The abdominal examination in particular, we need to look for any signs of guarding, rebound, or rigidity. There are lots of potential differential diagnoses for abdominal pain. They can be very varied, from functional abdominal pain, gastroenteritis, appendicitis, to intussusception, hernia, gynecological causes, and medical causes such as diabetes or Hirnlein-Schoenlein purpura. There are some rare but serious causes that we need to be certain that we're excluding, such as discitis, acute lymphoid leukemia, intra-abdominal abscess, and tumours. There are a number of other differential diagnoses, such as extra-abdominal causes, with referred pain in particular of pneumonia, and other medical causes. This is a nice summary of all the differential diagnoses that you can get by age group. Some diagnoses you can get obviously in almost every age group. Others are more specific for particular age groups. For instance, intussusception is much more common in the younger age groups, such as the infants and toddlers, and also the school age. Hirnlein-Schoenlein purpura is much more common in the primary school age children and less common in adolescents, teenagers. You have to think more about gynecological causes in the adolescents and older children. So sometimes thinking about the age of a child can help you think more about what you think the likely diagnosis is going to be. These are very common differential diagnoses in neonates and infants. Hernia, volvulus, and intussusception are much more common, as I said. Also, in the neonatal population, you have to think about necrotizing enterocolitis, particularly if they've been born prematurely. When you're considering differential diagnoses, you have to be very systematic. You have to rank them from the most likely to the least likely, and your history should hone these appropriately. You have to think about anatomical problems and where they relate to your examination findings. It is also very important to consider the most serious and what would happen if it was the most serious. It's also important to think about surgical versus non-surgical causes, abdominal, and not to forget that there can be extra abdominal causes as well, particularly in some younger children where they don't recognise referred pain that well. There are a number of red flags for abdominal pain. In any child that presents with drowsiness or unresponsiveness in any scenario, we're very worried. We have to really think carefully if they're looking shocked or septic, such as having a prolonged capillary refill time. If there's any abdominal guarding or rigidity, that can be quite specific for abdominal pain and show quite serious levels of systemic upset. You have to be very careful if there's bile or bloodstained vomit. If there's bloody or recurrent jelly stool, then that does point towards interception, but it's not always present in early interception. Any acute testicular pain has to be dealt with very quickly and seen by a surgeon as soon as is practically possible. Any pain in the abdomen after any significant abdominal trauma is also needs to be investigated carefully with scans, for instance. If pain is waking a child at night, and this does not just is not just for abdominal pain, it is a very significant sign. But it is important to remember that only a very small percentage have an actual true surgical cause. You have to think about how age influences differential diagnoses. Abdominal examination is critical in helping you to go towards a particular diagnosis. As I will show in the evidence later, it's very important not to withhold analgesia. In fact, the evidence, as I will show later, does point towards giving analgesia, and that does not affect your ability to perform a good examination and to get the right information out of that examination. You have to have a thought that the etiology of the abdominal pain is not necessarily intra-abdominal. It is sometimes important to have more than one examination to see if the findings are consistent. It's not always possible to have a definitive diagnosis, and it's very important to have a clear follow-up plan if, for instance, you are deciding to send a child home. So the management of abdominal pain in secondary care can involve antibiotic treatment. It may involve some fluid management. It definitely involves pain control, and there's a lot of evidence to say that paediatricians and other practitioners within paediatric departments are not giving analgesia effectively or efficiently enough. And of course there can be definitive surgery required in some cases. So in particular, I looked at whether specific tests or investigations are useful in abdominal pain. Are FAST scans such as abdominal ultrasounds important, abdominal x-rays, or in fact CT scans? So I will go through some of the evidence behind these in a moment. These are some interesting pictures. Here's an ultrasound showing gallstones. There's an abdominal x-ray which is showing signs of Hirschsprung's disease, and a CT which is showing gallstone pancreatitis. So there is a great deal of evidence that FAST scans, or abdominal ultrasound scans done in the emergency department, are very useful in blunt abdominal trauma if they're hemodynamically unstable. There was a very large study of 224 patients with abdominal trauma which showed that there was a high sensitivity for detecting intraperitoneal fluid, and it was also fairly specific with good positive predictive values and negative predictive values. In the subcategory of patients within this study who were hypertensive and had low blood pressure, the ultrasound was actually 100% specific for identifying all the patients with intraperitoneal fluid. It was also 100% specific for hemoperitoneum, and it showed a negative result for all the patients who did not have a hemoperitoneum. So the evidence suggests that the ultrasound is very effective, particularly if performed early in children who have had blunt abdominal trauma and are suffering the effects of low blood pressure. Abdominal x-rays. There was a widespread search of over 300 papers regarding abdominal pain just in children. These were found about 5 relevant papers from a wide date range. It showed that actually in 10% of cases, abdominal x-rays can provide diagnostic evidence and information which can support the management. But in those cases where it's thought there is major disease and that does require surgery, the usefulness of an abdominal x-ray can increase up to about 40%. Abdominal x-rays are useful to confirm diagnosis where there's a very high clinical suspicion already. They have a very high specificity for small bowel obstruction, for perforation, foreign bodies and calculi, but they're very low sensitivity if there's no radiological signs for ruling out obstruction. So it's not a great screening tool for major disease and abdominal pain, but as stated, if there's a very high clinical suspicion of a particular diagnosis, it can help to confirm that. Now I'm going to look at how useful pain scores can be for abdominal pain in emergency department. It is very crucial that pain is adequately assessed and dealt with appropriately. There was a huge study including almost 25,000 visits to Children's Emergency Department, and it showed that in half of these, 44.5%, they had documented pain scores. Those that were younger were much less likely to have the pain score documented, but interestingly, if there was a pain score documented, there was a much higher chance of analgesia being given. So this showed that in this particular group of children, very young children were often missing out on adequate analgesia, which was impacting on their clinical care, their diagnosis and their subsequent investigations. If very young children are still in pain, they're much less likely to cooperate with examination and with investigations being undertaken on them. So looking further at the assessment and management of pain in the emergency department, a retrospective study looked at the pain management of children in 123 hospitals after a fracture. They used a particular pain assessment scale in their triage, and they used that in 92% of the patients. But only 60% of patients were asked again about their pain when their observations were reviewed later. And significantly in this study, only 50% of patients who were rated as having moderate to severe pain were actually offered analgesia. The 6 to 15-year-old children were much more likely to be offered opiates than much younger children in the 0 to 5 age group. So this again shows that pain management needs to be improved following evaluation pain, and that again, infants and young children need much better management of their pain and are a population that are missing out. And there's a lot of other studies that show very similar results. So as some of you will know, there are a number of different pain assessment tools. There are 3 main paediatric tools. One's called the FLAC, another one is the Wong-Baker Faces Pain Scale, and a third one is the Visual Analog Scale. These are all used alongside a combination of self-report and behavioural assessment to get an overall picture of how much pain the child is experiencing. The FLAC score stands for Face, Legs, Activity, Cry and Consolability. It uses the patient's behaviour to assess their pain experience. It's used for children between 2 months and 18 years and up to 18 years in children with cognitive impairment or some form of developmental disability. In children who are non-verbal, the parent and carer can help explain the child's behaviour and help facilitate an accurate pain assessment. So in each category, face, legs, activity, cry and consolability, it is scored on a 0 to 2 scale. The total pain score is made from 0 to 10. And the person assesses the child briefly, observes them and scores each category according to the description supplied. These are how the scores are made up. And it's quite a good descriptive scoring system where anybody could really decide on what they score, and you could very specifically ask parents some of the questions about what the child is doing in relation to any of this score. Another commonly used pain assessment is the Wong-Baker-Faces pain scale. It uses self-reports of pain to assess a patient's experience of pain, so it's generally used in children aged 3 to 18 years, depending on their cognitive ability. You explain to the patient how each face will help you understand how much pain they have and how this makes them feel. So face 0 is very happy because he's not hurting at all and has no pain. Face 2 hurts just a little bit. Face 4 hurts a little bit more. 6 hurts even more. 8 hurts a whole lot. And 10 hurts as much as you can imagine, although you do not have to be crying to feel this bad. And the person checking the child's pain just asks them to choose the face that best describes how they are feeling and how much pain they feel they are in. The visual analog scale is a self-report pain assessment to try and find out how patients are experiencing their pain. It's generally used in children approximately 8 years and over and depends on their cognitive ability. So in this system, you ask the child to rate their experience of pain from 0 being no pain all the way through to 10 being the very worst pain. As you're aware, all these pain scales are only as useful as being alongside the physiological indicators of pain. They themselves cannot be used in isolation as a measurement of pain, but will incorporate physical behaviour and self-report. If, for instance, there's a very poorly child who's ventilated and sedated, the physiological indicators of pain can be helpful to determine if there is pain experienced, such as the heart rate may increase, the respiratory rate and pattern may change from normal, the blood pressure may increase, and the oxygen levels may decrease in relation to pain. It is, of course, very difficult to assess paediatric patients in the emergency department with all the noise and busyness. Children can often present with a number of symptoms which don't necessarily lead to an obvious diagnosis, and assessing their pain levels surrounding this can be very tricky in that kind of environment. This does mean that often we get a much later diagnosis, and therefore there's a great reluctance to start analgesia early amongst clinicians because we feel that we need a diagnosis before seeing what we need to treat. This is a further summary of Drendor's large study. Again, just to summarise again and remind that if there's no documentation of pain score, the odds of receiving any analgesia was the same as if you were visiting the department and had a very mild pain score. So clearly, pain score documentation in a number of emergency departments is very suboptimal in the paediatric population. In particular, infants and toddlers are one of the subcategories that very rarely have their pain score documented and therefore receive poor levels of analgesia. So we really do need to improve our documentation for acute ill and injured children and improve their pain management. In the long run, this will help with our diagnosis and help us assess and treat people more effectively. Another study by Goldman suggests that we really are underdosing our paediatric patients. The charts of 582 children were looked at, and it showed that only 9% of these children received opioid analgesia, and 77% of these opioids were given below the recommended dosage. So it's still a very controversial issue using opioids in the emergency department, even for children with severe abdominal pain. And often they're not used even in cases of suspected acute appendicitis. So again, another study by Green suggested again that we're not using enough analgesia in children with acute abdominal pain. 290 children from 5 to 17 years presented with acute abdominal pain to the emergency department. 14% of those who were seen straight off by the emergency department doctors received analgesics, and 15% seen directly by the surgical team received analgesics. But in this group of 290 children, 46.6% of them underwent a laparotomy. So it does show that analgesic use at the outset and presentation was extremely low, and this was despite them needing quite serious surgery. So I question whether this is really appropriate and whether we need to look again at our analgesic use in these subcategory of children. But of course, if we're going to use analgesia earlier, we need to know whether this is going to affect the quality of our assessment. So a randomised double-blinded placebo-controlled trial evaluated whether using IV morphine to reduce pain would alter the physical examination and the accuracy of diagnosis in children. Actually, what they showed was the IV morphine and analgesia very greatly reduced their pain score and did not sacrifice diagnostic accuracy, which was the same in of 80% in both the morphine and the placebo group. So both children had the correct diagnoses and the correct outcomes. They also showed in the subsequent studies that children with surgical abdomens continued to have persistent tenderness, palpation and percussion even if they'd had IV opioid use. Fentanyl is increasingly used in the emergency department, and intranasal fentanyl in particular is extremely effective in the paediatric population. Studies show that there's a very good early and significant reduction in pain in children using intranasal fentanyl by 10 minutes, and this is sustained throughout a 30-minute observational period. So this would enable doctors, such as surgical doctors, to examine the child. So it is thought, following lots of studies by Borland and by Cole, that if actually intranasal fentanyl is used either in the pre-hospital setting or perhaps by the triage nurse in the emergency department, this would help ongoing assessment and mean that children are in pain for a shorter period of time. So other studies support this. They suggest that severe abdominal pain should be relieved as soon as possible, and they suggest that there's no evidence to support the withholding of analgesia in acute abdominal pain in children. There's level 1 evidence that severe pain is best relieved by intravenous opioids or narcotics, and that these should be titrated in small aliquots to relieve the pain. They improve the patient comfort, and this doesn't increase the risk of errors in diagnosis or treatment. And it can be safe to be given before a full assessment and diagnosis is made in acute abdominal pain. So, if we are going to enable pre-hospital remission of opiates, or the triage nurses in the emergency department to be able to initiate some earlier opiate analgesia, we need to look at the evidence of how we can time this correctly and whether this impacts on any of the outcomes. There was an interesting study by Fry which showed that those presenting in acute pain, as determined by the visual analog scale at triage, did not have any adverse outcomes even if they were given IV morphine by experienced emergency department nurses on the initial triage. They showed that in their study they had 349 patients and their median pain score was 8.5, and the reduction in pain score, the median reduction, was down to 4 after an hour after being given intravenous morphine. The respiratory rate, heart rate, oxygen sats and blood pressure all showed small but statistically significant reductions over the 60-minute period. There were only 15 adverse events, which involved 10 episodes of hypertension, 5 episodes of desaturations. No interventions were actually needed other than some supplemental oxygen, and there were no episodes of reduced levels of consciousness, loss of consciousness, bradycardia or low respiratory rate. So this study suggested and supported the idea that experienced emergency department nurses could effectively initiate IV opioid analgesia to children in acute pain, and this had very minimal change on their physiological parameters. So this process could improve the time to analgesia for patients in acute pain. A Cochrane review of studies into opioid analgesia see whether they mask clinical findings and reduce the ability of clinicians to diagnose abdominal pain found 8 studies fulfilling its inclusion criteria. They showed that the use of opioid analgesia in acute abdominal pain does not alter the risk of diagnostic error or the risk of error in making decisions regarding treatment. So there was no value in withholding analgesia prior to surgical review, for instance. So all the evidence points towards giving analgesia much earlier, and in fact stronger analgesia such as opiates. So why do we need to give this to children early? Well, if the pain is well controlled, they're much more comfortable during their examination, there are much better diagnostic outcomes from the examination, and it's then subsequently easier to perform any diagnostic testing such as ultrasound, and so more information can be gained from these investigations. If a child goes for a scan and is it still in pain, they are much more likely to move around in the scan itself, and therefore the images may be of poorer quality. It has been shown that in multi-system disorder or trauma, titrating opiate medications can help with both the diagnosis and the further investigations. So now I'm going to look specifically at appendicitis. It is extremely common in the paediatric population. The incidence from birth to 4 years is 1 to 2 cases per 10,000 children per year. In the 10 to 17 age group, it's 25 cases per 10,000 children per year. The overall lifetime risk of a patient having appendicitis is 7%. So, whilst appendicitis is not the commonest presentation to the emergency department with abdominal pain, it is one of the highest causes for admissions and for surgery rates, so it makes up a vast majority of our workload and the intensity of our workload. Appendicitis can be classical or atypical. Classical appendicitis is usually fairly easy to diagnose, but actually atypical appendicitis is common in children. The features are that there can be no migration of pain in up to half of children, no signs of anorexia in half of children, no focal tenderness in greater than half, no rebound tenderness, and the time course of the pain being less than 24 hours can be very common. Unfortunately, for diagnosing appendicitis, there is no single diagnostic test. There are a number of diagnostic difficulties and quandaries as follows. In doing a urine dipstick test or urinalysis, pyuria can be present in 30%. Full blood count is not sensitive nor specific, but can help guide. Ultrasound has an 87% sensitivity and specificity is about 89%. However, in approximately 10% of patients with appendicitis in the child population, up to 10% of these, the appendix will not be visualised. And in up to 20% of children without appendicitis, again, it will not be visualised appropriately. So ultrasounds can be a bit misleading at times. CT scans show higher sensitivities of 91%, 94%, but there is a radio-induced malignancy risk in a single CT in a 5-year-old of 20 to 25 in 100,000, so it's not without its risks. These are some interesting pictures of scans. This is a CT scan showing appendicitis. And this is an ultrasound which shows appendicitis with some free fluid as well. So here's quite a significant meta-analysis of investigations for appendicitis. In particular, it was looking at ultrasound and CT use in diagnosing appendicitis. The literature was reviewed from 1986 to 2004 and showed 26 studies involving paediatric patients, and these were just under 10,000 patients. It had both prospective and retrospective studies, and it looked at the false positive, true positives, false negatives and true negatives outcomes of diagnosis of appendicitis with these images. So again, these are the results showing that CT has slightly higher sensitivity and specificity, but ultrasound is around the 80% marks. As mentioned before, ultrasound is without many sequelae, but CT having a higher sensitivity, you still need to consider the level of radiation associated with this. So, looking at the evidence behind indicators to diagnose appendicitis, this was a meta-analysis of 24 studies which looked at clinical and laboratory variables and whether some of them had higher discriminator values for appendicitis. It looked at the receive operator characteristic areas and the positive and negative likelihood ratios of these variables in diagnosing appendicitis. It showed that the main things that helped discriminate most strongly for appendicitis were the inflammatory response, the descriptors of peritoneal irritation, and the migration of pain. The inflammatory response variables are granulocyte counts, proportion of polymorphonuclear blood cells, white blood cell count, and CRP. The descriptors of peritoneal irritation are rebound tenderness, percussion tenderness, guarding, and rigidity. So these were very strong for perforated appendicitis, and appendicitis was much more likely when 2 or more inflammatory variables were increased, and very unlikely when they were all normal. So individually, all the clinical and laboratory variables are weak discriminators, but when they're combined, they have a very high discriminatory power. So a ROC plot shows the relationship between sensitivity and specificity. For example, if there's a decrease in sensitivity, this can result in an increase in specificity. The closer the graph is to the top and left-hand borders, the more accurate the test. And if the graph is close to the diagonal, there's a less accurate test. And the likelihood ratio is given by the derivative at any particular cut point on the graph. This is some of the likelihood ratios related to appendicitis. It shows that fever has quite a high likelihood ratio if present, as does rebound tenderness and migrating pain. CRP, again, has a high ratio, as does a white blood cell count. And some of the prediction scores, which I will discuss in a moment, so that's the Averado, or the Mantrels, and the pediatric appendicitis score, have good likelihood ratios and are useful to derive information from. This is the Averado appendicitis score, which is documented clearly in Earle's journal article. It has a scoring where different features give it different points. So the acronym is MANTRELS, which is migration of pain to the right iliac fossa, anorexia, nausea, tenderness in the right lower quadrant, rebound pain, elevated temperature, leukocytosis, and a shift to the left of the white blood cell count. If you remember earlier, I mentioned atypical appendicitis, and this may be slightly less effective in those cases because they don't tend to have the migration of pain, the anorexia, and the movement into the lower quadrant. But they're scored of 1 to 2, and if there's less than 5 in the total score, this tends to rule out appendicitis, but a greater than 7 is very suggestive of appendicitis. The total that you can score is 10. It is much more effective at ruling out a diagnosis of appendicitis than actually diagnosing it. And very intermediate scores will often overestimate the diagnosis of appendicitis, so it does have to be used with caution and it alongside the clinical picture. This is another validated prediction score system, which is combining the two different ways of scoring, and shows that, again, if you get an intermediate risk, it's between about 4 to 8, and very high risk for appendicitis is greater than 8 or 9. It shows you some of the different ways that we can check for appendicitis, such as getting the child to hop and seeing where that causes pain, and that's in the pediatric appendicitis score. Often surgical doctors will not want us to commence antibiotics until surgery has either been performed or that they have reviewed the patient to make sure that they do think it is appendicitis. This was looking really at whether antibiotics could be as effective or more effective than actually performing an appendicectomy. And this is where 369 patients were randomly allocated to either surgery or antibiotics compared to a control population. It showed that of these random allocations, about half of the patients just allocated antibiotics completed their treatment course, whereas 92% of the patients who were allocated the appendicectomy actually underwent surgery. However, the efficacy was extremely good for antibiotic therapy alone. 90% had good efficacy, and this is the same as with surgery. There were very similar amounts of minor complications between both groups, and actually major complications were 3 times higher in patients who had an appendicectomy. So it does appear that antibiotics could potentially be a safe first-line therapy in patients with acute appendicitis. This is just showing you the different arms of the allocation for this study and showing how many patients received surgery versus antibiotics and which ones were lost to follow-up. Another study by Wilms, showing Cochrane review of 5 randomised control trials, showed that 73% treated with antibiotics had a cure within 2 weeks without any major complications at a year, and 97% of those with a appendectomy had a cure within 2 weeks with no complications at less than a year. However, the upper margin of the 95% confidence interval for antibiotic treatment crosses the line, so that this does actually create a slightly inconclusive outcome, and the quality of these studies was seen to be low to moderate. So appendectomy currently is still the gold standard for presumed appendicitis, but antibiotic treatment could be considered as a good alternative in patients with specific conditions where surgery might be contraindicated or pose a high risk. So I looked at whether there was evidence for specific antibiotics in appendicitis. The SIGN Scottish guidance shows that antibiotic prophylaxis in appendicitis is highly recommended. It suggests that IV antibiotics should be started as soon after the diagnosis of acute appendicitis is confirmed, and this should be directed against gram-negative and anaerobic organisms such as E. coli and Bacteroides species. However, most of the diagnoses guidance out there, such as the SIGN and the NICE, does not suggest a particular specific antibiotic. It says it's very much dependent on the trust and the department that you work within. There have been studies comparing the effectiveness of extended spectrum versus much narrower spectrum antibiotics to children with appendicitis, and it showed that actually extended spectrum antibiotics showed no advantage over narrow spectrum ones in children with very uncomplicated or complicated appendicitis. For your reference, I've put some of the abbreviations that I've used during the presentation in case they're not immediately apparent. And these are the references that I've used. And this is the second page of references. Thank you for listening to my talk. I hope you found it useful.